going to talk about some pediatric changes to the protocols this year.
Yeah, so we did quite a few changes, none of them earth-shattering, but just a lot of cleaning up. So I just want to give credit to some docs that helped with me. Matt Hansen is one of my fellow pediatric emergency physicians at OHSU Dornbecker, and Casey Rowe and Stacy Valenzuela are two emergency medicine residents that are very interested in pediatrics and helped me out with this.
Cool.
So the first change we made was with DEXAMETHASONE. We made the dosing more consistent with what we're giving in the hospital. So we increased this dose to 0.6 milligrams per kilogram. So that's double the dose that we're used to. We're still topping out at 10 milligrams. And we've added it, for some reason through the years, we forgot to add it to the croup and asthma pediatric boxes of those protocols.
So
now they're in there. Please remember to use dexamethasone for the croup, asthma, and allergic reactions. And the oral solution is very concentrated. And for kids, if you remember, if you're at a house, if they have something to flavor it with, it may go down quicker, but it's a pretty small amount. And usually you can just squirt it in their mouths, and before they know it, they've choked it down.
It's actually not that bad. I when we first got it, I tried it. It tastes like vitamins.
Yeah. So the changes as regards to pediatrics, we were kind of very vague about the CPR rate in pediatrics. So we're going from what it was, at least 100 per minute, to specifically to what it should be, as 100 to 120 per minute.
Good.
So the same as adults, so that's pretty easy. We really are trying to emphasize the early use of epinephrine in pediatric codes. As you know, most pediatric codes aren't going to, especially younger than adolescents, are not going to have shockable rhythms. So they're going to be in PEAs and asystole, and we really need to get epinephrine on board early. So in a pediatric cardiac arrest, after you get the airway going, start compression, someone should be working on access. Probably the best access is an IO, and get the epi on board. We had some controversy over cooling post-cardiac arrest. Both pediatric hospitals had different ideas of who should be cooled and when. So our compromise is cooling is going to be okay for adolescents over 12 years old. So if they're 13 and older, and probably with a presumed cardiac arrest, so maybe kids with cardiac disease, they were exercising. It's not for drowning or drug ODs.
So primary ideology, cardiac
arrest.
Presumed cardiac.
So sudden cardiac arrest without any other obvious cause. And the other thing we kind of cleaned up is we're discontinuing use of putting drugs down the endotracheal tube. Not only it probably doesn't work at all because the absorption is pretty poor, it also can worsen their respiratory status. So again, on newborn resuscitation, you should be putting in an IO if they need drugs. Perfect. Which is fairly unusual. So for pediatric bradycardia, we're just emphasizing in kind of the first box decision point is to just make sure that you're having good ventilation and oxygenation. Again, most causes of bradycardia in kids, especially young kids, is usually inadequate ventilation, and they're hypoxic and they become profoundly bradycardic. So just make sure you're ventilating them really well, have good oxygenation. If that doesn't do the trick, they're still bradycardic, then you're going to move to more specific treatment with CPR and epinephrine.
And I think it's a good point to remember two-person bag valve mask, right?
Yes.
Making sure you have padding under the shoulder, so optimizing that patient position so we can make sure that we've got good ventilations going.
Kind of a big change is, again, from the AHA is we're not going to be doing intubation and suctioning just for meconium. So it used to be if there was thick meconium and the baby was born depressed, not reactive, we were going to intubate and suction. Again, the evidence has been pretty overwhelming. It doesn't help at all, and again, it delays ventilatory support is what they primarily need. So we don't want to do anything to delay definitive ventilatory support. So if they're born through thick meconium, they're pressed, wipe them off, stimulate them, and then immediately do bag valve mask ventilation. Don't worry about intubating them just for meconium. Now, if you have to bag them for a while, then consider intubation. But The other thing they found is for monitoring a baby during neonatal resuscitation, relying on doing pulses is very unreliable. And it doesn't matter whether you're a layperson, a paramedic, or a physician. Feeling for pulses can be very unreliable, especially in a slimy little baby. So they really want to get away with feeling for pulses to assess resuscitation. So you should slap on a pulse ox and a 3-lead EKG as soon as, if the baby doesn't like perk up with a couple bags and start screaming their head off, you need to get on 3 leads and a pulse oximeter. The other emphasis has been on maintaining normothermia. Again, hypothermia really increases the risk of death in neonates. So again, the most important thing is as soon as they're born is to dry them off and stimulate them, and then once you get them dry, cover them up with something clean. Yeah. And then resuscitate them if you need to, but really be cognizant of, and they can cool off very quickly because again, they're soaking wet when they come out. They have a very high surface area to their weight ratio, and they can just get cool very fast. The other thing is infant CPR should be just 2-thumb methods from now on, no more 2-finger methods for CPR.
Good. I find that to be clunky.
Yeah.
So most people, so 2 thumbs encircling, wonderful.
And then the cord, delayed cord clamping, we used to do it for a couple of minutes.
Yeah,
now
2 to
the
3
AHA
minutes.
is just recommending 30 to 60 seconds.
Good.
Again, reminding you, if the baby needs resuscitation, immediately clamp the cord and cut it, because you don't want to be dangling attached to mom while you're trying to resuscitate a baby.
Totally.
So if the baby's unstable, immediately cut and clamp it. If they're stable, screaming at you, then wait 30 to 60 seconds and cut it. Other minor changes for ondansetron or Zofran. We've lowered the age where you can give it without calling online medical control. So now it's down to 6 months you can give ondansetron without calling MRH. So we've had to change the dosing. So we've made it fairly convenient. So 2 milligrams is for ages 6 months to 2 years, 4 milligrams from greater than 2 years to 12 years, and then after 12 years, it's 8 milligrams. So, a half, a full, or 2 tablets for kids. So that should be pretty easy. The good news is Zofran has a very wide therapeutic range, and so it's very hard to overdose somebody on it. And we've made that the same dose for IM if there's profuse vomiting, but I found virtually every kid can take this. If the kid's old enough, tell them it may not taste very good, but it really easily dissolves under the tongue. And so even if they're profusely vomiting, you can usually get it under the tongue. But otherwise, you can give it IM.
Right on.
Or IV if they need an IV for another reason. Fentanyl, again, we've doubled the dose for the IM and intranasal dose to be more consistent with what we're giving in the hospital and having better effects. So again, ibuprofen's, there were some discrepancies in between the PEDS guide and the protocols. So we changed it. So it's contraindicated in kids less than 6 months of age. And that's just because their kidneys are young and immature and can't handle the ibuprofen. But we put it down to 6 months to be consistent across the board. And it should be, if parents are using it, it should be at least 4 hours after the parent's last dose. So you don't want to stack ibuprofen doses.
Yeah, not on top of each other.
Because that, again, can injure the kidneys, especially if they're dehydrated. Amiodarone, again, was just a correction. It was miswritten. So for unstable ventricular tachycardia, amiodarone is 5 milligrams per kilogram slow IV push. IO needle size, we're now using the blue IO needle down to a newborn. So you could actually get rid of your pink needle if you'd like. Hopefully we're not seeing too many babies that are less than 3 kilograms, but I'll leave that up to your medical director. But now, just be careful. The bones are small, and don't put a lot of pressure when you're using the drill. The drill does, just like when you're drilling wood, the drill should be doing most of the work for you. So just some light pressure. As soon as you pop in, stop. I have had people drill into their hand going through a neonate's leg, so just be careful.
Wow. That doesn't sound like good times.
No, it wasn't.
Yeah.
It's a lot of paperwork. I think this is our last change. So the ALTE protocol has mostly just been changed in name. The American Academy of Pediatrics, which does a lot of the guidelines for pediatric treatment, decided to change ALTE to calling it a brief, resolved, unexplained event, or a BREW. Not the most catchy phrase,
Definitely not catchy.
I must tell you. So things that have changed, it's an event lasting less than 1 minute, and we've changed the age, so it's less than 1 year of age instead of what we currently have is 2 years of age. And just as a reminder, these events can be either cyanosis or pallor, some kind of change in their breathing, either absent, decreased, or irregular breathing, a marked change in their muscle tone, either hypotonic or hypertonic, or an altered mental status for some reason. And so, most of these events are either due to reflux, where the kid, is either fed, a couple minutes ago or even sometimes a couple hours ago. They reflux, they get a little bit in their lungs, and they have, an exaggerated diving reflex, and they'll stop breathing and change color, and usually they cough it up and then they're fine. The other most common reason is having a seizure. The other important thing is if they meet these criteria, and if the parent, the kid usually looks great afterwards. That's part of the definition is now they look normal.
Mm-hmm.
Obviously, if they look sick, they need to go into the hospital anyway. But even if they look great, they're back to normal, they still need to go into the hospital. So if the caretakers are refusing to go to the ER, you need to call online medical control and have them talk to the parents or the caretakers.